Good evening, good afternoon, good morning. Today we will have a fifth webinar, Oracles of Eye Innovation. As a members, as a organizing with Chris Morrill, Michael Mrochen. Thank you so much for this effort. Tonight or today we will talk about presbyopia. Presbyopia is very hot topic. We have a lot of clinical study, a lot of innovations, so many new products, so many new assessment protocols on the market, and we will see in the market, hopefully. We have wonderful speakers again. First speaker is Scott MacRae. He is one of the most experienced and respected refractive surgeons in the world. He is Director of Refractive Services in the Department of Ophthalmology in University of Rochester and editorial member of 3 refractive surgery journals. And most recently was the Senior Associate Editor of Journal of Refractive Surgery. He published more than 400 studies, and so he trained surgeons. So now we look forward to hear his talk. I don't want to take your time, and now we listen him. Thank you so much to join us, Scott.
Well, thank you very much. Today, I'd like to talk to you about some of the assessment of preoperative requirements and outcomes after presbyopic cataract surgery. And in particular, I want to share with you some work that's been done with SimVision and Gecko by Two Eyes Vision. This is a system that was developed by Susana Marcos and her group in Madrid. Very exciting system, which allows visual simulation. It looks like a virtual reality system, as you can see here on the upper right, but it's not virtual reality. You're actually simulating different things that we see at distance and near under different lighting conditions as well in a very systematic way. The beauty of this is it's non-invasive and allows pre-IOL patients to actually simulate multifocality. In addition, it identifies if someone is a suitable candidate for a multifocal. It allows them to literally take the multifocal that you're testing out for a test drive under different lighting conditions. And you can also do the same thing with contact lenses. So the contact lenses industry is also very interested in this for multifocal contact lenses as a way of pre-screening patients to see if they'd be successful contact lens wearers with a multifocal. The treatments can be personalized. So you can literally, when you put this on, you can actually do a extended depth of focus optic, like a symphony in one eye, and a simulation of a other multifocal trifocal lens, Optometrica, or a number of different trifocal lenses as a choice. And you can actually simulate those, as I'll show you in just a bit. And it's a binocular system. So, well, how do they actually do this? SimViz works by using an optotunable lens. It's a custom high-speed electronic driver. And it does temporal multiplexing, which uses periodic variation of optical power at 50 hertz. This creates a static appearing multifocal image for the patient. And that's actually simulated over on your left here, where the lens is actually changing and alternating at 50 hertz. So, well, how did they actually set this up? The SimViz pattern was actually taken from defocus curves and actually simulates those defocus curves for different lenses. So you can take a multifocal IOL, put it on an optical bench, create a defocus curve for that, and then emulate that with the SimViz system. So, and when we do that on an optical bench, or when Susana's group did that, they found that there was really excellent correspondence and very high correlation with the actual lens on the optical bench. The clinical value of this solves with some of the problems that we have. It's very hard for us to explain multifocal vision to patients. We can describe it, but we can't demonstrate it. This system can actually demonstrate the multifocal vision to patients under varying conditions. It's also difficult to manage their expectations, but by using this system, you can actually give them a reasonable idea of what it would be like to look at distance vision under photopic or mesoptic conditions, as well as near vision under photopic and mesoptic conditions. This allows you to manage their expectations. The other problem that we have, the other barrier, is that it's very uncertain. We don't know which patients are going to be doing well with this system and which patients are not going to be doing well. And so this allows you to actually simulate this for the patients so that you get a really reasonable idea as to whether they'd be a successful candidate or whether they are not going to adjust to this at all. There's currently no commonly used screening tool, so this fits a need for that. Patients are currently not offered multifocal lenses as frequently as they could be if we had a way to actually describe to them visually what they would experience with a multifocal. And they can't try the lens on before implantation. The beauty of this is it allows a patient to take the multifocal lens, and you can test varying different types of multifocal lenses. You can take them for a test drive, let them simulate it under a variety of conditions, as I'll show you in a few minutes. The clinical and commercial value of SimVis allows us as clinicians to sell more premium IOLs if it's appropriate for those patients. But just as importantly, and I really like this, it allows us to screen out prospective unhappy patients. One of the biggest barriers, I think, to multifocal lens, the multifocal lens strategy is that we can't determine what that 3, maybe 5% of patients that aren't quite happy with their multifocal with. It's very difficult to screen that out. And for patients that, let's say, have a subtle irregular astigmatism, this will allow you to literally screen that out by simulating it for the patient. When they notice that they can't see well with it, then they would probably defer from having a multifocal. This allows better patient satisfaction because you're both speaking a more common language in terms of the multifocal demonstration. It allows to compare across different intraocular multifocal lens solutions. And it also saves time because you have a way of actually demonstrating this to the patient in terms of their multifocality. And from a business standpoint, it saves money in terms of chair time. It also offers a competitive advantage in the sense that practices that are using this are perceived as being very advanced in terms of using technology to actually articulate this to the patient. And also, it increases the multifocal presbyopic commercial availability in the sense that it makes it more accessible for them to understand the effect of a multifocal. So, well, how does this actually work? Well, the binocular visual simulator is a wearable device. It's binocular. You see through it. So you can actually walk around a room. And I've actually, in my office, I've actually had cars out here. We've turned it on at night and simulated what it looks like to look at headlights. And the system actually has a headlight simulation program that we've actually worked with. It has a wide field of view over 20 degrees. It is programmable, and I'll show you the tablet that we use to do that in just a few minutes. It allows for simultaneous vision, so one can actually simulate a multifocal. You can actually simulate an extended depth of focus lens in one eye and a trifocal multifocal IOL in the other eye, so patients can actually compare in real time what it would look like with the different options. You can also simulate monovision as well. So this is actually what it looks like in the exam lane. Here you can simulate with distance images. This is under photopic light conditions, and you can also do a near test and demonstrate that to the patient. In addition, you can document their visual performance, and Dr. Susanna Marcos and her group have developed a scaling system so that you can actually document how successful they are with distance and near vision, what their level of satisfaction is with that, with each different type of multifocal. So with this, you can demonstrate a monofocal lens, an EDOF lens, a trifocal. You can do mix and match, as I mentioned before. The SymVis patient gives patients preoperatively what they would experience postoperatively if they decided to try multifocality. So this is taken from some work that Dr. Marcos's group has done, taking clear lens extraction patients, and with these patients, they actually do the SymVis simulation and do a defocus curve, as you can see in the lower green scale on your left, and then compare that to the patient after they get a fine vision trifocal in a group of 12 patients. And what you see is they actually perform a little bit better, as shown here on the dark dotted dashed line group. They actually perform slightly better with the fine vision trifocal. In another study they did on cataract patients, again, the patients did the SymVis simulation and did a defocus curve, as you can see here. And then after they had their cataract procedure with the fine vision trifocal, this was their defocus curve with the actual intraocular lens. And you can see there's a really excellent correlation between the two defocus curves. But what I really like about this is that the patients actually did a little better with the fine vision trifocal than they did with the SymVis. And for me as a clinician, I think that that's reassuring in the sense that you're under promising and over delivering. The intraocular lens itself actually does a little bit better than the SymVis. And part of this is probably because the patients have some cataract. And I'll show you in just a minute that you can do this in patients with mild and moderate cataract. But if you have a patient with a severe cataract, obviously this is not going to allow them to get good simulation. So I'll talk to you in just a few minutes about that. So we can use different lens implants, the Panoptic, the Symphony pattern, the fine vision trifocals. And this just compares the SymVis measured in a group of patients that were presbyopic, developing a defocus curve, and comparing that to the defocus curves that were published in the literature for each of these, the Panoptic, Symphony, and fine vision trifocal. So this allows us to actually do a performance evaluation using what Dr. Marcos and her group call the multifocal acceptance score, or MIS. This is done, they can do this with simulating contact lenses and then see how they do with that. And they can also do it with intraocular lenses. I like the way that they've set this up in terms of the upper left corner set of images are basically the photopic images that one sees on a screen about a few meters away in the exam lane. And the nice thing about this is that it uses all different spatial frequencies. There's an image of a face, which is basically multiple spatial frequencies, high spatial frequency, low spatial frequency. And similarly, they use a high spatial frequency carnival party image, and an image from San Francisco streets showing a streetcar. And this shows you what you see with all different levels of contrast sensitivity and spatial frequency. So in addition, they also use a dash light, as you can see on the middle left figure, and then a nighttime map that often some will see in a car when you're driving. So they actually can simulate that under low light conditions. This lower screen basically shows a stereo vision test that they do in addition to that. And by doing that, you can actually create a matrix. Dr. Marcos's group creates a polygon. This is if you treat the far vision with a monofocal lens in both eyes, and this is the pattern that you get. Now, if you compare that to a bifocal, multifocal IOL in both eyes, you notice that the near vision actually gets a little bit better, and you can compare that to a monovision lens where the near vision does get better, but the stereopsis actually is reduced. And you compare that to a modified monovision shown in the gold, where the stereoptics is improved as a result of the modified monovision. And you can actually measure visual performance using this with this SYMBIS system. So one of the
very limited time. I'm very sorry. I don't want to interrupt you.
Okay. So this is the very last slide, basically. And the big question is, well, can you do it in patients with cataract? This is a study basically that showed you can do it in 9 pseudophakic patients. The scatter index varied between 1.1 and 11.75. The IOLs are similar pre and post, and the correlation is very high. So in summary, it's non-invasive, and it allows us to get a personalized approach with presbyopic modalities. Thanks.
Thank you so much. This is really wonderful presentation and wonderful technology. I'm sure in the future will be very helpful for us, will be more common used. And now I will move next speaker. We will discuss detail during panel discussion. So next speakers is James Wolffsohn. James is a professor of optometry at Aston University Research Center for Healthy Aging. His main research areas are development of evaluation of ophthalmic instrumentation and contact lenses, intraocular lenses, and tear film. He published more than 200 academic papers. He is the academic chair of British Contact Lens Association, having been a past president. Thank you so much, James, to join us.
Yeah, thank you very much for inviting me. So I thought I'd talk to you a little bit about our innovations, both for prior to surgery and also after surgery. Normally I'd acknowledge my conflicts. Well, I'm actually talking about some of these innovations from some of the spin-out companies that we have from Aston University, which is where I'm based, but principally the ones relating to Wolffsohn Research and Aston Vision Sciences. So first of all, prior to surgery, one thing that surgeons now acknowledge more than ever is the importance of the ocular surface and the quality of that ocular surface, both for doing their biometry, but also then in terms of the quality of vision that they get and not inducing dry eye type symptomology, taking someone who has ocular surface disease or damage and then doing ocular surgery on them. And likewise, if we're doing presbyopia with other options such as contact lenses, again, your ocular surface is really important. So one of the innovations that we've been working on is better ways of assessing the tear film and the ocular surface. So this is a way of doing it. You'll all be familiar with children's toys, particularly around sort of fireworks, where they're spinning something around with lights on it. And as far as your vision is concerned, you get a lovely circle of light. Well, essentially, this uses the same technology. So it's a wand of light where we can control the colors along that wand and the spacing of those lights to create a persistence of vision. So essentially a complete circle or a complete plane of light on the patient's eye, and yet with a relatively low level of illumination. So we're not making the patient uncomfortable or bleaching the image that we're getting at all. So essentially we can create images either of things like rings, where we can then detect the separation of those rings to look at ocular surface shape. We can look at the breakup of those rings to look at the tear film itself, or we can create a constant image to get good quality imaging of the anterior eye or things like the meibomian glands. And we can do that with a relatively small device. This is the prototype here. And we can do that either with the stability of a slit lamp base, or we can do it as a standalone instrument that you use on a patient in their individual environment. And then with the software, of course, then we can do images and reports based on that. So some fairly simple technology, and at the end of the presentation, I'll loop back to this idea of a good ocular surface and taking information from that. But let's move to a different concept now, and this really is one about following up patients, and this is one of the companies that I work very closely with, and that's Rayner in the UK. And so they've developed a digital platform for their surgeons to help follow up patient outcomes, because again, this is becoming increasingly more important with the need to for manufacturers, of course, to collect data on the ongoing use of their devices post regulation and registration, but also for surgeons in terms of audit and to show quality. So this is a cloud-based system that works on any of your sort of smartphone or tablet type devices. And essentially, it can assess the quality of care delivered to patients from a patient's perspective, the health gains after surgical treatment, and do that over time. How does it work? Well, essentially, the system requires the surgeon to register the patient at the time of surgery and the lens that they've been fitted with. But by giving some simple information, then the patient receives an email from the system telling them that they've been registered and asking them at various time points to fill in some basic information. That's available to the surgeon then over time, and I'll show you these screens to map how that they're doing, but also in terms of the company, then for them to see how their product is doing with in the real world. And it's not a medical device, it's just purely a way of collecting information. So in terms of the registration, very fast and simple, some very basic information about the patient and obviously their contact details so that the app can contact them, but also then information about the hospital itself. So again, that the information can be sent back to the surgeon. The patient then gets a friendly email to themselves telling them about the surgery that they've had and explaining what it's going to ask them to do over time. And then they can fill in some very simple information about how they're feeling about their surgery, for example. It takes less than 5 minutes, and that information is then built over time. So in terms of when the data is collected, initially 1 week after surgery, then there's more information about their satisfaction with the outcomes and their spectacle independence and target vision after 3 months. More information at a year, again, in terms of satisfaction. And then finally, some data about additional procedures, any additional procedures that they've needed to have done at 2 years, and then finally 3 years after surgery. So you can see very quickly, this information is building up. You as the surgeon or the practice don't need to be following those patients through. That's done automatically for you. And that then populates your own dashboard in terms of the patients that you've fitted and the information that they've collected. Likewise, it can generate then some information for you in terms of how well your patients are doing compared to other people's patients. Of course, private information for you, but potentially useful in terms of how you move forward, and then a whole load of benefits for you as a surgeon. And I can well imagine that more of these systems will appear in future to allow us to better track those patients over time. And now let's flick to some of the apps that we've developed really for, again, pre and post surgery or contact lens fitting, any type of presbyopia correction, where we're trying to collect information on patients in a better and more standardized way. And the way we principally do this is using the iOS platform, so Apple devices. The main reason being is that their screens are very standardized. So we know what we're getting in terms of luminance and contrast and resolution. And also the devices can talk to one another. and that has huge advantages in terms of presenting stimuli at different distances. So we can have everything from a simple acuity chart. So essentially with a tablet or a phone, we can take control of a distant screen through a Apple TV. And so literally you can swipe and mirror your screen, but actually instead of having to do a complete mirror, the app automatically knows that one is a distant screen where you present then your letter acuity target, but actually on your near screen, it can give you a series of letters. I'll show you in the next screen that you can score yourself. So we can do things like distance visual acuity with a tablet or a phone and a monitor, or you can then do near acuity. Of course, the advantage of doing things like distance acuity for presbyopia is we can do defocus curves, so we can rapidly move through a series of presentations. We can randomize the letters, for example, so we don't have any of those issues. And you can point directly to the line that they got to last time to help in terms of getting them quickly through what can either be a very onerous test. At intermediate and near, then, we can use the phone to be the remote for the iPad, and we can do that at any distance that you prescribe for the patient. And literally on the remote, you can click a letter that they don't get correct. It automatically scores that for you. And when you get to a scoring criteria of 3 out of 5 incorrect, it will automatically give you those values. So again, you're not having to work it out or hope that the technician has done that correctly for you. And again, clicking on a line automatically indicates to the patient where you want them to read. We can move forward and actually use more features of these devices. So for example, in reading speed, we've mimicked the Radner test, but actually it listens to their voice. So it can accurately time the beginning and the end of the presentation. It's watching their face and the distance between the eyes. So we actually know how far away they're holding the device, if they're cheating and bringing things closer to them. And at the end, it can automatically plot out their curve, give you their normal reading speed, their critical print size, and their threshold visual acuity. When it comes to contrast sensitivity, again, we can take advantage of the app and the presentation originally by Campbell and Robson in the 1950s of what that function actually looks like to a patient. But instead of with your individual tests having to measure one spatial frequency or maybe a couple depending on which test you use, CSV 1000, we can do 4 spatial frequencies. But actually with an iPad, you can literally just trace your finger over where you see the tops of the bars, and you've got a complete contrast sensitivity function in less than 30 seconds. And we can also do that at distance. Obviously, they can't reach and touch the distant screen, so they use the iPad to lift up the bars to be the appropriate distance. We can also do other things. This is a test that we're working on now, dynamic visual acuity. So very short presentation of a Landolt C in one of 4 directions with crowding bars. And again, this has been used in things like sports vision to really tease out differences in visual acuity. Moving on to glare, obviously the last presentation included that as well from Scott. We use a halometer that we built, so a sleeve that goes onto an iPad and allows us to move a target from behind seeing to non-seeing. When they first see it, they let you know, and then you can randomize it, check that they can really see it, and you can plot out a complete profile then of their seeing curve. And we've shown that this is able to differentiate, for example, different patterns with different types of intraocular lens, multifocal intraocular lens, and also then things like segmented lenses. In terms of patient satisfaction, some people will be familiar that we did a near activity visual questionnaire a number of years ago, and that's been extensively used in the literature. But of course, it's come out of date now that we've got all of these modern devices that people are using for near as well. We've also collaborated with people like Tariq Aslam to have a look at their subjective questionnaire, and we'll tie those in together in a moment. But we're now updating that questionnaire with Novartis for their clinical trials, so there'll be a new version available. And again, we have that in an app form to make it easy for patients. But Scott was talking to you about the multifocal acceptance score. Well, we have something similar. So essentially, you can take their objectively measured glare, and if you divide that by their subjectively reported glare before surgery. Of course, they've got cataract, they've got some glare there. We can actually create a score, and the higher that score is, the more likely they are to be satisfied, because actually the amount of glare that's objectively there doesn't bother them that much. Conversely, if you get a very low score, it suggests that actually psychologically they can't cope with the glare even from cataract, and therefore are less likely to be successful with a multifocal. And then finally, just to tie back into how I started in terms of assessing tear film, we have more sort of dynamic apps. This is one that we've developed to look at dry eye. So when you start the test, it allows you to relax your eyes. What we're actually measuring at that time is their blink rate. You can see the camera appear there where they're out of line. So that's what it's doing. It's analyzing their facial features and how they're blinking during this process. And then as it moves on, you'll see some questionnaires. So these are the standard dry eye questionnaires, initially the DQ5, then it moves on to the OSDI. And so you can answer the 12 questions of the OSDI. And all while it's doing this, it's actually watching the patient. So it's looking at how they blink, for example. So we get information about their blink rate, their completeness of blink. You'll see that in a moment with the video when it analyzes that. So here's that standard questionnaire. Takes a little bit of time to get through the OSDI. Sandy's another one. So Sandy's one that has 2 scales on frequency and severity. And at this point, they would hand it back to the examiner. But actually what's happening is it's analysing their face. You can see I did this with one of those plane trips that we'll dream about in the future because we can't get out of our countries. But essentially, it's taking all that information about my eyes and how I was using them during that. It can monitor the distance I was away and the tilt of the screen. And all that information is available there for you. And you'll see it will actually give you that information in terms of the time of each blink. And you can go back and review that. So here we go. So it's done its analysis. So these are each of the blink times, and you can click on any of those to check the blinking at that particular point of time. And then it's got all of that data for you. So there's amazing power in what we can do with this app type technology. So thank you very much for your attention.
Thank you so much. And now we have a wonderful panel group. Dee Stephenson will join us. She is ophthalmic surgeon, interested microincisional cataract surgery and implantation of premium intraocular lenses, as well as custom laser cataract surgeries. She is the president of American Board of Eye Surgery. And of course, John Marshall, very happy to see you again, John. And John is professor of ophthalmology in Moorfields Eye Hospital. A lot of awards, a lot of papers. Everyone knows him, of course. And now we have very nice questions. First of all, I would like to discuss first Neuhan questions. He is asking first speaker, is this technology is different than Vivior technology, which is Michael Mrochen technology? Maybe we have just few minutes. I'm sure other panelists has a lot of questions, so just briefly.
Well, I'm not familiar with all of Michael's technology. I think that, you know, the advantage of the system is it's pretty simple, and I think we're all trying to condense a test that would allow us to assess whether somebody's going to be a good candidate or a poor candidate, and also give them the options available. So I think that this system, I can speak from my experience with this system, and I haven't worked with Michael's system, but I know Michael designs wonderful things. But this system allows us to do that. And I think that we can even condense it even more so that it provides a quick way to do that type of evaluation.
Okay. I hope it is answer for you, Nohan. Now, I am asking panelists, do you have any questions? Dee, Marshall?
Well, I would just make a comment regarding, our goal in all of this for cataract surgery, LASIK surgery, all surgery is the quality of vision. And I think that we ignore this problem. We are used to getting 20/20 or 6/10 vision, and we don't really understand all of the stuff that's happening. And of course, our ocular surface is so important. And remember, all of our pre-op testing is just a moment in time. So it's a moment in time when that particular test was taken. So to have something that the patient can actually use that Dr. MacRae was talking on, would make really good sense, because it's more of a qualitative evaluation, not a subjective thing, because we can all give us our subjective answers to something, but something that can be qualitative, I think, is a very useful tool. And, just like training our brain and having all these scores, I think that both of these innovations are could be quite an improvement, at least in the United States, for some of the things that we're doing. That was more of a comment, not a question, but, and how long it takes this stuff to come to market in Europe and the United Kingdom is so much different than how it is in the United States. So it'd be nice to have some of this technology. And James, again, you're so brilliant. I love listening to you speak. And Scott, I've not heard you speak, but I know who you are. And I have always been enthralled by your genius and how you can make something very complicated kind of straightforward. So kudos to you both.
Thank you.
Thank you. I just one comment. I know John wants to talk, but I have a comment after John. Go ahead, John.
Well, basically, I think I tried an early version of this out in Athens. And the one thing it convinced me was that I didn't want any lens which wasn't just a straight sphere, because I saw all sorts of annoying perturbations with any of the innovations. I think that the question I have, Scott, is how does this system work usefully, given that the patient has an accommodative range? So you're dealing with an artificial lens substituted into a system where the patient still has the ability to hunt with a whatever accommodative process they have left. And I think that was a problem with my experimentation with the early system. I found it very difficult to fixate on the given fixation points because my lens and my visual cortex, presumably, were saying we can do better than that. So how did you cope with accommodation?
You mean in the studies that they were doing, those were all presbyopes, even the clear lens extraction patients, they were presbyope, but they probably had a little bit of a combination that was sort of contaminating it. The one thing that is reassuring to me is if you look at those curves, they actually did better, like in the patients that got implants with multifocal implants, they actually did better after they got the lens implant than they did on the SimVis. So even if they were accommodating and sort of compensating with accommodation pre-op, they actually performed better in terms of the defocus curves, at least, with the actual lens implant. That to me is reassuring. And I like the idea that it's sort of understating or giving them a little less of the defocus curve than they would get when they actually have their cataracts out and they have a lens implant. So, but I agree, the proof is in the pudding. I mean, if the patients, it'll be interesting to see how how well this does predict. It seems like everything that Susanna's group has basically shows that it does pretty well predict what their experience is going to be with a multifocal. And then the real question is acceptance. The one comment I was going to make is right now we have as clinicians, we say that you're going to be multifocal. We say that you're going to get glare or some glare and halos. We say that there might be a reduction in contrast, but we have no way of actually showing that to patients. And this, I really like this because you can show it to patients so they can make a decision. If 6 months down the road, they don't like it, at least you can say to them, look, we talked about this, we showed you that, we did our as much as we could possibly do to demonstrate that. I think that, I see a lot of patients that are referred to me that are not happy with their outcome. And one of the main reasons is that they didn't know what they were getting into. And with this, it allows the patient to actually see the glare, the halos that occur with these, the slight reduction in contrast that occurs. The other thing that's really interesting is that you can do it with your text. So your texts are actually empowered to explain it better to patients as well. And my text really loved actually going through the whole process and seeing what multifocal vision was like, seeing that there is a little loss in contrast, seeing there is a little bit more glare and halos. It's not overwhelming, but it's there. So they can actually describe it more accurately to the patients.
Well, and again, you can give this to your surgical counselor, and boy, howdy, already what the time frame that they spend educating patients usually is not me. I give the initial information, but then it's fine-tuned by my surgical counselor. So to me, this would be a really powerful tool for a surgical counselor.
We do have Toby Neuhan in the line. Toby, you had an additional question?
Yes.
Thank you. Thank you for inviting me. The additional question is, this is quite impressive to see and to give the patient the information what he has to expect. But most of our patients which come are cataract patients, and they have low vision, 2200, 2050. How good must the patient see before the surgery that the information we get with this system, that we can believe that it works?
Yeah, it's a great question. I don't think that Susanna's group has worked that out exactly with their, using different instrumentation. You could probably predict that, but I agree that on patients with more mature cataracts, this is going to have less predictability, and it probably is not going to function as well.
Yeah. Okay. Very helpful. But it's impressive, and one always has to start with something and to enhance it. And for clear lens exchange, it's definitely helpful. And
if you remember the work of Fergus Campbell back in the 60s, one thing that may be helpful here is if with the cataract patients, would be to actually have an image generator in the near infrared, and that would get around most of the problems of scatter and still enable you to determine the optical efficiency of the system and the differences between the various lenses. So there are solutions there, and it's a reasonable first shot. But as I say, when I tried the early prototype, the only lens that I was happy with was a straight sphere, but that's perhaps because I was being too pernickety and didn't want halos and didn't want any peripheral distortion, etc.
Also, this innovation, this technology is very useful for monovision, because even we are doing not only intraocular lenses, when we do LASIK surgery, of course, we can put contact lenses, different eyes, but this is easier way, non-invasive, shortest way to show patients how is monovision. This is really every day we are doing LASIK and we are doing a lot of patients monovision. It is really not easy to explain sometimes. But when we show this vision to patients this way, it is really very valuable. My only quick question to Scott, before surgery for multifocal lens, how long time patients wearing this device? How long? 10 minutes, 1 hour, 2 hours?
Yeah, the testing, we haven't, I've been working with it just for a short period of time. We haven't used it extensively at this point in time, and I'd like to work with their group in terms of trying to reduce the amount of time that it takes, because I think these technologies are they're going to be used if you can do them in a reasonable amount of time. But if it takes an hour to do this, I'm not sure it's going to have good adaptation. The actual testing from Susanna's standpoint, she can get through a test in 5 to 10 minutes, depending upon the subject.
Okay.
So,
we do have Carlos Doronzo on the call. Maybe Carlos, you want to patch in? Maybe you can make a comment. Carlos is working close with Susanna Marcos, and he's an excellent scientist involved in one of the inventors and founders of SIMVIS. So maybe Carlos, you can comment.
Yeah. Hello, everybody. Yeah, it depends. I mean, it's a see-through device, and you can do with the device whatever you want to do. So if you want to do through focus visual acuity curve, well, it takes time. But if you want to perform just a perceptual judgment, well, it takes probably 30 seconds. So it depends. The good thing is that you can switch from correction to correction in just a few seconds.
Carlos, can you comment? I know you did some work on the neuronal adaptation, how long it takes, let's say, the brain to get into this. Maybe you can comment on that.
Yeah, we published a paper in PLOS ONE, I think it was, a few years ago. And what we did is to study the neural adaptation to different simultaneous vision corrections. And those were, I don't remember, but it was an adaptation period of just 1 minute that was reinforced during the experiment. And the experiment took a few minutes with each correction. And we saw that the adaptation, the neural adaptation was really quick. So we estimated that it was possible to at least to estimate what the final acceptance was going to be in a period of just a few minutes.
Can I make a comment on that? One of the things that intrigued me in the early days of refractive surgery was the number of patients that ended up with perfect vision by all our measurements, but they really didn't like the effects of the surgery. And it turned out that because they lived with their aberrations for 20, 30 years, suddenly to have their coma corrected and other aberrations corrected, they really didn't like that. And that was another adaptive element. Eventually, they accommodated neurologically out, but that took several months for most patients to actually come to terms with the fact that they'd had their aberrations corrected that their cortex had been used to for so long. So there's a quick switching mechanism, but there's also a very slow adaptive switching mechanism in the visual cortex.
Yeah, I agree with that.
So I would like to ask question, James Wolffsohn. It was really wonderful presentation. We didn't talk about this technology. I think this is also feature. This is a very nice, especially in dry eye measurements, visual acuity, and this is very easy way, blinking rate. This is, I'm very interested also dry eye, and this measurements is really very nice. My question is, this technology is in the market at the moment?
So the Rainer app is on the market already. The other apps that you see at the moment, we do specifically for companies, and we make a bespoke version for them. We haven't released it generally on the market, but we are working towards that.
Thank you so much.
James, can I just ask you also, we all know that various disc procedures have a real problem at the corneal apex. And many years ago, one of my fellows, Ralph Zabel, produced a 68 ring disc to try and correct that. But of course, it couldn't correct it as much as we had hoped. So we ended up with a slightly more complex series of Fresnel fringes, which gave us 222,000 data points. Now, I'm not suggesting that that's going to be a routine clinical device, because it was quite large. But how do you cope with curvature at the apex with your system? Or do you make the usual fudge factors?
So, of course, there are some fudge factors and stuff. Our system is not particularly designed just to do topography. So it's not designed to be a very accurate topography device. It is more for tear film, but obviously a side effect is that you can get topography data. And you're certainly right that the apex is very complex, particularly in disease pathology. So this would be fine for detecting the pathology. It's not necessarily fine for giving you accurate aberration details of what you're going to get from your cornea. Having the multicolored rings helps, because it means that we can have them closer together and still separate the images from them. And we can very easily flash between different rings. So again, we can build up a pattern which in a better way than you can do with a standard topographer.
And one final follow-up, in terms of your glare and halos, etc., there's a lot of complaints in the clinics from elderly individuals of modern LED headlights with a high blue component.
Absolutely.
Have you done any spectral distribution?
We haven't, but we can replace the LED that we use to measure the scatter with different LEDs with different profiles. I did work a little bit with Joanne Wood with her driving track in Australia on some of these issues, and also overhead lighting now, which of course has moved very heavily to LEDs of very different color spectrums to what we're used to. But it's still early days in seeing the impact. But I know personally that some of the ones are very blue in the spectrum and give you much more scatter, and also presumably impact pupil size, which is very important when you've got a multifocal implant. So there's a lot of work still to be done in that area.
Thank you.
I have a personal question, a very quick personal question is, I underwent monovision LASIK about 4 years ago, and it was done with a femtosecond laser. And as we all know, femtosecond lasers are creating nice linear patterns in the stroma. And, I don't have rainbow glare, which clinically has been reported, but I can see wonderful diffraction patterns if I look at red backlights of cars in the night. So first of all, I think I need one of those monocles from John to correct my distance vision. But my question is that an assessment you could do on more, I wouldn't say coherent, but more small bandwidth light waves to see if there's diffraction patterns associated?
We certainly obviously can change the light that we're using to any color pattern that we want to. We're mapping out in some ways the disability, so how much it actually obscures your vision. And we could do that in multiple different wavelengths. Like many of these tests, it's like repeating defocus curves. You gain more information if we did that in different lighting levels, but then there's the trade-off of how long the participant is going to be compliant with the test. But it certainly is possible.
Michael, get a polarizer.
Okay.
Michael, you need some distance driving glasses for your monovision.
Yes, one of those monocles. I mean, I'm very happy with my monovision. Probably because I'm one-eye sighted, but these diffraction patterns by night, especially if you drive behind one of these modern electric cars like Tesla, we can wonderfully see diffraction patterns. Yeah.
Now, next speaker is Dr. Robert Ang. He is one of top presbyopia surgeons in the world. He is a senior consultant and pioneer ophthalmologist at Asian Eye Institute and in Philippines. In addition, a busy clinical practice, Dr. Ang devotes a significant amount of time on research and clinical trials on presbyopia. And now he will introduce us the first in human clinical results, laser scleral microperforation. Now we have recorded presentation from him, and then for discussion you can ask questions. Our panelist, Dr. AnnMarie Hipsley, will join us. We will discuss about this.
Hello, my name is Dr. Robert Ang, and I'm here to present the clinical outcomes after biomechanical therapeutics, specifically laser scleral microporation. It is the first time we are presenting results of this innovative treatment. I am a consultant of ACE Vision. So presbyopia, we know that there are many postulations about the theories of presbyopia, and we think one of the mechanisms of presbyopia is stiffening of the sclera and the internal eye lens. So the problem is we think there's some component of age-related scleral rigidity. As you can see, when you are young, the sclera has a little bit of flexibility, but when you're older, there's some amount of cross-linking that happens, making the sclera rigid. And the result is it makes the ciliary body move less. So in LSM, we use erbium YAG laser on the sclera, and what we hope to do is do some uncross-linking of the collagen fibrils of the sclera. And when we do this, we hope that we lessen the scleral biomechanical stiffness and allow ciliary muscle forces to move better. Lens changes shape better, and it allows for more accommodation. So this animation, as you can see, is where the laser is firing, and it creates micropores and causes some sort of a scleral, we call it scleral uncross-linking. So it hits scleral myofibrils and it restores the mechanical efficiency of the natural accommodative mechanism. So in this study, so far we have recruited 44 eyes or 22 patients, and the goal is to do LSM treatment in 4 quadrants in the sclera near the limbus in a 5 by 5 millimeter matrix using a proprietary erbium YAG laser. So this is the theoretical treatment, and in the next slide, I will show you a video of one of our treatments. So as you can see, the sclera, we put ink marks on the 4 quadrants, so supernasal, infranasal, supertemporal, infratemporal, and there's a nozzle under the laser, and you can see that the laser will fire on the sclera transconjunctivally. So it's like a matrix firing transconjunctivally to hit the sclera. So this is 1 quadrant, so it takes about 10-15 seconds to do 1 quadrant. Sometimes it's unavoidable that there are blood vessels that we hit, as you can see here. And there's a corneal shield that we use to protect the iris and the pupil so that the patient doesn't see a lot of glare during the procedure. So this is the 3rd quadrant. And this is the 4th quadrant of the patient. So it doesn't take a long time to do this, and it's totally painless on the patient. I'm actually talking to the patient to give them instructions where to look. And this is on the operating microscope, I focused on the area treated, and as you can see, there are micropores, and we hit about 70% scleral thickness, and you see this dark grayish hue, and some punctures on the conjunctiva. So 4 quadrants are treated like this. So inclusion criteria for our study is age of at least 48 years old with at least a reading add of a 1.5 diopters, but emetropic presbyopic. So MRSE of within half a diopter. No other previous surgery. Some patients have had vision correction. So our current population of 22 patients, the mean age was 54.5 years, and the mean reading add of our patients was 2 diopters. So here is a graph of the MRSE. We wanted to show you that we do not alter refractive error. We do not change the refraction of the patient because we did not touch the cornea. So from pre-op to 6 months, the MRSE more or less is stable. Here are uncorrected visual acuities. Distance vision remains stable. Intermediate vision significantly improves from 0.2 to 0.07 to 0.01 at 6 months. And near vision also significantly improves from 0.47 to 0.25 and 0.18 logmar from pre-op to 6 months. These are uncorrected visual acuities, and these are distance corrected or best corrected visual acuities. Corrected distance vision is similarly is same. Intermediate vision is significantly better, and near vision is dramatically better from 0.46 to 0.16 at 6 months. So this is a summary of visual acuities. In the first column is uncorrected distance vision. As you can see, they remain 20/20 throughout from pre-op to 6 months. Intermediate vision has improved, so they usually start off as 20/30, and then at the end of 6 months, they're usually 20/20 or 20/25, and uncorrected near vision, they're 20/50 or worse. And at 6 months, they're usually about 20/25 to 20/30, or about J2 to J3 in almost all patients. Distance corrected intermediate vision is significantly better, and distance corrected near vision is also significantly better. So we wanted to take note of the near visual acuity distribution, distance corrected near vision. So pre-op, only 14% of patients were 20/40 or better, but at 6 months, 90% were 20/40 or better, and 71% of patients were 20/25 or better, distance corrected near vision. So a significant improvement. So these are day 1 slit lamp photos. As you can see, you see the micropores. They're about light to dark gray on day 1. And there's some there's conjunctival injection because we hit through sclera. So we irritated the conjunctiva a little bit. So there's a lot of redness in the treated areas. No pain from the patient, but they feel a little bit of scratchiness because I guess there's some defects in the conjunctiva. But so far, no significant complaints. And at 1 week, you see that the conjunctival injection has mostly subsided. The eye is turning quiet, and you see that the micropores are very visible through the conjunctiva. The cornea and anterior chamber are quiet and untouched. So patients do not notice or feel anything different. They don't notice any difference in far vision. So in conclusion, LSM or laser scleral microporation is a safe and effective procedure for restoring visual performance in the near and intermediate vision. The mechanism of action is still being studied, but our results are compelling, and most patients gained at least 0.3 logmar in their near vision. So they notice an improvement. At the beginning, they see a little bit, but as they go along, they see better and better. And the most important finding that we have is no patient experienced any complication that decreased their best corrected distance vision. So our final thoughts about this new innovation in terms of patients, they do notice an improvement in their quality of life. So they use less or almost no reading glasses. Actually, we try to tell them to try their natural near vision and not to wear reading glasses throughout the 6 to 12-month follow-up. So most of them comply and they're functional. How about for the clinicians? For me specifically, I have other presbyopia treatments, but when I correct presbyopia, I sacrifice some form of distance vision. In this one, it's a significant addition because they are for presbyopic patients. And what excites me the most is it doesn't affect far vision and it doesn't affect quality of vision. So we are very excited about this new laser scleral microporation technology, and we will continue to do more patients and show you more results in the coming congresses. Thank you very much.
Thank you, Bobby. I'm going to ask a couple questions. Do you anticipate that there'll be a continued improvement in the near vision, the accommodation over the rest of the follow-up period in the study?
So what we notice is on day 1, they notice a mild improvement, but not a lot yet. And we encourage them and we actually push them to keep using their eye without reading glasses. So I kind of explain this as some sort of a muscle exercise, push their ciliary muscle to move. So the patients do experience improvement from 1 day to 1 month and then to 3 months. That's the biggest jump in improvement, is from 1 month to 3 months. And then they're more or less stable. So we are in some patients up to 6 months and they're still improving. So I'm hoping that they keep on improving, but our longest follow-up is still only up to 6 months at this point.
Okay, and is this a treatment that the company anticipates will need to be repeated down the road, or is it seen as a permanent presbyopic correction?
So we are ready for both eventualities. So actually, this is the generation 1 laser, and we're working on a generation 2 laser with a tracker because we need to have a software that detects the micropores so that we can do additional treatments on the same spots. So we are anticipating that maybe over time, the presbyopia will worsen because of age. No? So this treatment is not a refractive change. It is some sort of a rejuvenation, or we help the muscles move. So we anticipate a possible degradation over time because of aging or lessening of effects. So I think we have to be ready with some sort of a touch-up.
Okay. And as someone who I think of as Dr. Presbyopia, where do you see this fitting into your current treatment armamentarium of presbyopic treatments?
So I think this is a niche product for emmetropic presbyopes. So we have presby-LASIK for correcting refractive error and presbyopia, but whenever we do some presbyopia treatment, whether we change asphericity, we sacrifice some far vision. So when I do presby-LASIK, I don't do bilateral presby-LASIK. I do 1 eye standard LASIK, 1 eye presby-LASIK. So if I have patients who have had conventional LASIK and grew old, this is the perfect product for them because it is just a natural presbyopia happening without any correction of refractive error. So the post-LASIK is a definite market for this. And the natural presbyopes, you wouldn't believe how many natural presbyopes come to the clinic wanting something because they are now wearing reading glasses. So these 2 markets are quite big, and I think this is a perfect product for them.
Chris, can I make a statement here? I've been following this for some time, and AnnMarie and I have discussed this on numerous occasions. I think this has tremendous promise because this is the first time we have had any form of treatment that preserves the dynamic range of the system, i.e. this is not a click-stop system. You're not putting in a lens with focus here or here or here. And I think what's happening here is that by putting those lesions in the sclera, you're actually, as it were, weakening the sclera and changing the fulcrum from which the lens and the zonules are acting from. So by actually weakening that system, you're enhancing the residual accommodative mechanism that the patient will have depending on their age. So I think this is quite fascinating, and I congratulate you on these results and the Mark I laser. And I know, AnnMarie, it's going to involve me in hours and hours and hours of discussion with you, but I look forward to the Mark II.
Thanks, John. To kind of echo what you said, this is a true biomechanical treatment. That has an optical result versus LASIK, which is an optical, most of the things out there are optical solutions that have optical results and optical compromises. So this is really very interesting because, of course, my background's in therapy and biomechanics. And so John and I get along a lot with our vocabulary, but it's a difficult transition, I think, and it was a very long journey to get people thinking about this biomechanical effect. And, modeling has been very helpful for us. And it's more of a restoring the natural relationships with the ciliary muscles, the lens, and the zonular complex. And you're right, when we age, these anatomy go behind the lens and lose their ability to put the right forces on the lens to get it to move. So we've seen this in our modeling, and we've seen this in the UBMs. It's too bad we don't have better diagnostics to really see inside the eye. Hopefully we'll have that in the future, but it's more restoring those relationships that basically allow the eye to do what it does. And we don't know, we don't have enough data. We have 300 patients from a previous prototype, and this data actually is better than those data. And we think because of the changes we've made by making these tighter micropores and going down to a smaller distribution of these pores, and the Gen 2 will definitely allow us to go into a land where we can dosage this, and potentially you have a different dose for an early presbyope than you do a later presbyope. The difficult other issue is not to compare, is if you ask me, well, does it regress? Well, presbyopia progresses. So that is a totally different way to think about things. So we can't stop you from getting more presbyopic, but potentially we can halt the progression of it. Our patients, I did a paper that shows that if a normal untreated eye person gets more presbyopic as you age, a quarter diopter per so many years, our patients do not get more presbyopic on that same rate. We don't know anything more other than just that observation. So being able to dose it and do a time, eye-matched, age-matched population and getting lots of data will give us some better answers how to titer this and customize it.
Yeah, and it's interesting technique.
AnnMarie,
Well, it's quite exciting to know that we now have not only lens-based and cornea-based and pharmacologic-based, but the actual scleral-based presbyopia correcting is awesome. I mean, AnnMarie, this is just so exciting. And, I've been following your group, Ace Vision, for a while with Mitch Jackson, and you should be so excited. This is very, very exciting technology.
Yes, it's hard to be pregnant for 15 years. I just have to say.
I bet.
And I told John or someone earlier, medical device and being the inventor of a device and seeing the vision of it and trying to get something elegant and measurable and obviously able to predict the result in advance, which we talked about earlier with the SimViz stuff, I think is key in the technology actually having a life cycle and getting to market and being in your hands. And, there's a lot of people been doing things in the sclera for a really long time, 40 years in fact. And Spencer Thornton, I learned a lot from him. God rest his soul, but I've had a lot of help from people like John Marshall and encouragement and lots of big giant champions, George Waring III, so many people that just wanted to see this thing happen. And, most of them aren't here anymore to watch it. And so, John, please don't go anywhere because it's coming next year.
I'm keeping away from all those viruses. And in fact, there's a gathering of more than 6 people.
Yeah. And thank you, Dee, for that comment.
AnnMarie, I have a question. I'm a bit curious because I saw a lot of black spots with thermal effects, and I saw we have Ralph Brinkman. I hope he's still there. Ralph Brinkman on the chat. Maybe we can patch him in and comment a bit about what he thinks about these thermal effects. And maybe briefly, Ralph Brinkman is one of the most known medical laser scientists in the world. And I'm very glad he's on this call. So Ralph, maybe you want to comment on what you think is going on here, thermal-wise, tissue-wise.
Yeah, thank you very much for the introduction, Michael. Very interesting approach. So I haven't heard from this approach, but I know from other people using different laser sources like the holmium laser or even at 1500 nanometers. So I'm wondering, what is the advantage of the erbium YAG laser and which laser parameters did you use? So do you really produce pores which fill up later on, or do you project on some kind of a little coagulation in the surroundings, and how is the healing reaction? So, I mean, I wonder a little bit about the dark rims on the sclera. So this looks like a little scaring. So do you do a high repetitive erbium YAG pulses, or what are the laser parameters?
Sure, good question. So first, what you're viewing is actually viewing the choroid through the subchoroidal lamina. We're not through that lamina, but you can visualize the choroid. You can actually visualize this when you're still up in the lamina fusca of the layer of the sclera. Today, we've chosen to keep the depth consistent with our previous studies to corroborate those studies. The Gen 2 laser, I'm just addressing the micropore basement that you're looking at. The Gen 2 laser, we will not have to see anything because we will be able to accurately use the OCT, the novel OCT we've developed to actually see between each pulse, and we can basically stop it when we want to. Today we don't have that. This is an optomechanical scanner. To answer the question about the parameters, it is a 2.94 erbium YAG laser, and of course, this laser is ideal for connective tissue. We actually are excavating that pore. We're actually creating a true three-dimensional pore. So it's not an incision, it's a three-dimensional pore. This pore, we used to use a proprietary collagen to fill in and train to put a scaffold to train the myofibroblasts to not form a scar or to cross-link. And we then did a study showing we had no difference between our healing effects once we were able to decrease the parameters of the laser to be below the Professor Marshall required 50 microns of thermal damage zone. As soon as we reduced that thermal damage zone and we reduced the pulses, so we're using now a 1 long pulse and maybe 2 short pulses, and we've reduced the amount of pulses and reduced dramatically. I think we're almost at 25 microns of thermal damage zone. So once we fine tune those parameters, we actually don't get any coagulation. We don't have any heat buildup. We decrease the heat stacking. tremendously through some experiments we've been doing at the Institute of Laser Medicine in Ulm. And so we've been working extremely hard on, scientific-based backing of the exact mechanism of that one pore, and then pore-to-pore relationships and the physics between that matrix are being developed now to, again, start a dosing mechanism based on scleral modulus. So I don't know if that helps you answer that. I'm familiar with the holmium YAG. Actually, it's a thulium YAG technique. I'm not a fan of that, only because I don't, we being from the orthopedic and therapeutic realm, we used holmium YAGs a long time ago in the 90s to try I was in sports medicine. I actually worked with professional sports, and we did lots of studies with this in the glenohumeral capsule. And what we found in those results were that the capsule, it was very temporary. And once the capsule lost the effect of the holmium YAG shrinkage, it became looser than it was before, and we ended up doing capsular surgery to capsular repair surgeries. And so we abandoned this technique. So it does already have a history of creating some hysteresis, the holmium YAG, once the person starts using that capsule again. So again, if you get this mechanism moving, assumably, we do have some other side effects from this, which might be, you do it young enough, you can keep this lens moving, and assumably we keep the connective tissues, the capsule around the lens and the lens itself moving, and trabecular meshwork, which is elastic, moving, we can increase the health of the eye and the physiology and potentially longevity.
Just one thing in relation to your wound healing, unlike when we're using lasers on the sclera for glaucoma and the blebs fill in, here we're not interested in the epithelial infill, because that has no biomechanical component. And remember, downstream, you can further control the scleral regeneration by mitomycin and other very simple drugs that are routinely used in the clinic. But Ralph, I don't, there are lots of other lasers, but having mortgaged her house 5 times, I think AnnMarie doesn't want yet another one.
I'm convinced that this wavelength is perfect.
For sure, I'm not concerned about the laser, but a little about the wound healing and whether this effect lasts for longer than maybe a year or so, because we know that the sclera and cornea, we have collagen regrowth, and I hope, and likely the sclera will become stiffer again. So I think you did animal experiments, or you did some experiments with porcine cornea. So did you do also stress strain measurements, and could you really quantify the weakening or the increase in elasticity?
Yes, we actually did do some experiments with the University of Alabama, and we did show, we were able to demonstrate with use of changing the interocular pressure, the biomechanical changes. We haven't published that yet. We did publish a paper, novel cross-linking, where we artificially cross-linked the sclera. This was with the National Taiwan, I think it was presented in ASCRS. This study showed us that we were able to decrease, change the biomechanical properties of the sclera to match younger patients' properties. So those were 2 key experiments leading to this. So the third thing that we're working on now is a finite element modeling. Another paper on the wound healing actually was published already. We did with the Singapore National Eye Center, showing the impact of collagen versus no collagen in the wound healing and the promise of this to be lasting. We do have patients out 10 years that were done with our prototype who are still not wearing glasses. They're in their late 60s. But we also have other patients from our previous data that it varies 3 to 5 years. We need more data that's stratified because, of course, a 42-year-old is not going to need as much accommodative restoration as a 58-year-old. So you sort of have to separate these out into these groups because you're not going to be able to average that because if this is a natural phenomenon, the brain is not going to give a 40-year-old 3 diopters when he or she only needs 1. So that's an issue, and that'll be part of our stratification of our FDA study.
So if there is not more question, our time limitation, we need to finish. It is really wonderful, endless discussion. It was wonderful meeting to be together. Wonderful speakers, very valuable panelists. So hopefully next time we will be together. Our next speakers, next meeting webinar will be also around 2 months later, and on April, and hopefully we meet you again. We may invite you again. And our meeting usually in YouTube, more people can reach us to see our presentations. We will always announce and we will share with people in social media these talks. Thank you so much.
Thank you.
Thank you.
Thank you.
Bye-bye. Thanks, everybody.
Thank you. Thank you, everyone.
Bye-bye.